She's also going to work on her personal weight loss to get herself set. So the idea is now strength building and weight loss pre-surgically, so that she's as strong as can be post-surgically. So with Michelle, we did a lot of hip opening. She warmed up just by using the bars and jogging in place. She did a lot of that instead of elevating herself necessarily. And did a lot of abduction and adduction. For her, it wasn't just for pain management, it was pain management and increased mobility. She has very limited range of motion compared to, on the left compared to the right, and comparatively to what normal range of her hip is, she's very limited. She walks, she limps, so she has an antalgic gait. She doesn't have a lot of internal rotation, and therefore she doesn't have a lot of external rotation in her head. Yeah, she was losing a lot of sleep, sleeping on her sides. Oh yeah, functionally she could not put her sock on. She can't do this. She couldn't do this to put a sock on, and she certainly can't do this now. So we worked on that in the pool a lot, just that movement to get her functionally doing certain things. Okay, so come on down. Some of the other things we did, like the figure 8, which we did to try and get her, we're really focusing just on the movement of, really isolating the movement in her hip joint. Yeah, this is her good hip. So if you notice when she has to do this, she rotates to her pelvis to compensate. So it takes a lot of concentration for her to isolate that hip joint to move it. So with the pool for her, we never really got to using the jets because we really needed to work on just isolated mobility. She really didn't have the strength to go against the jets. It would have just really pushed her out of her range of motion, and it would have been too forceful. Just the water alone, just sitting water was enough resistance for Michelle. And we did a lot of this repetitively, over and over, the same things over and over and over again. And we didn't need to do an extensive amount for different strength building. Michelle hadn't done a lot before that. Anything we did was an increase to what she had been doing. So you can see she fatigues, and it's harder for her to keep that motion going. So we were going to do pushing in and out, feet parallel. So you have to really try and keep your knees together. There you go. So 3 different foot positions: parallel, toe out, toe in. And she's doing something where she's lifting behind her for her hamstrings or pushing straight out, and her feet are parallel or turned out or turned in. That's definitely the rotations coming from the hip, and it's affecting her hamstrings or her quads directly for the lineup of those muscles. And then toe in. So that toe in comes from hip rotation, not sickling your feet. So here, the idea was, well, you were going to let your body float out a little bit, Michelle, so you were really sidelined. Yeah.
yeah, I can do it.
And if this Michelle really needs more control, stay the sideline plank on the other side. So she has a little harder control here. She lost control here. She's still using her right leg over her left. So she's compensating the distance between her legs with her right leg. I thought where you weren't coming across your body as much. Well, here she's going to, when her feet were turned out, she's an external rotation as she's lifting, so different muscles than when she's lifting internal rotation. So you turn your toes in, your hips go to internal rotation, you turn your toes out, your hips go to external rotation. When she's doing this motion, because she's already wide here and she's toed out for external rotation or toed in for internal rotation, it's not necessarily affecting her quads or hamstrings as much as it is the movement right at the joint, the smaller rotators of the joint that's keeping her, the head of her femurs turned in her acetabulum, which is the pocket in the pelvis. Yeah, without rotating your pelvis. So you should feel that right at your hip joints. Like on your toe. Yeah, exactly. And that's simply just moving the head of the femur and the acetabulum. And at this point, Michelle's acetabulum is probably not really formed around the head of the femur, but it's probably got a lot of flat area in there, so she can't go this way and this way. It's not this socket that she can rotate in. So she really doesn't have the freedom of movement in her pelvis, in her hip. On this leg, she always rotating as a unit. Her hip, but the head of her femur is not moving freely in the acetabulum. Go on your toes, Michelle, push your toes, your left toes down. There you go. You go flat on your right foot. There you go. So now, don't rotate your pelvis. Okay? No, well, you can't reverse arthritis. We can make it more comfortable for her while she's at that level. But arthritis, you can't do anything about it. But the more you move the joint where the arthritis is, the more it becomes lubricated, if you want, and the more freedom of movement you'll have. But, because Michelle wasn't really doing a lot of exercise or any exercise, and she had this arthritis building up, she had a lot of calcification and just there was nothing left in her. So the pool kind of doesn't really buy her time for the decay process, the breakdown process, but it makes her more comfortable in the meantime.
I'm so excited.
I think after the first time she was in, she said, oh my God, I feel so much better. And I think that her gait pattern changed within a month at the most. Don't you think?
Yep.
Yeah, she really had this little gait. She just kind of walked little steps. She had a longer stride. She didn't turn as she pushed off.